My name is Hayley Suchland, and my presentation is over triangular fibrocartilage complex injuries. The anatomy of the TFCC includes the TFC, also known as the triangular fibrocartilage discus, the radial ulnar and ulnocarpal ligaments, the meniscus homologue, and the extensor and flexor carpi ulnaris tendons. A TFCC injury is the tearing of the ligaments, tendons, or cartilage of the ulnar side of the wrist. This soft tissue is susceptible to tearing and degeneration. The central portion of the TFCC is not well vascularized, making it harder to heal. For a type 1 TFCC injury, a person could fall on their extended wrist with their forearm pronated. A traction injury could occur, or a fracture at the end of the radius. This is known as a traumatic injury. For a type 2 TFCC injury, it is usually associated with positive ulnar variance or ulnocarpal impaction, also known as a degenerative injury. Signs and symptoms include pain on the ulnar side of the wrist, tenderness in the spot between the ulnar styloid and flexor carpi ulnaris tendon, which is found between the volar surface of the ulnar head and pisiform, 95% sensitivity and 87% specificity for foveal disruptions of the TFCC or ulnotriquetral ligament injuries. There is also pain with ulnar deviation or radial deviation, along with weakness, clicking, or decreased movements. The special tests for TFCC include the compression test, the stress test, the press test, the supination test, the piano key test, and the grind test. People who are more predisposed to TFCC include the elderly, people who have had previous injuries of the ulna, people who use repetitive motions of the wrist, who have stiffness, laxity, weakness, or overuse. TFCC is recognized through the signs and symptoms as well as through special testing. A few differential diagnoses include hypothenar-Hammer syndrome, which is a lack of blood flow to the fingers, ulnar carpal impingement, which is the ulna impinging on the distal radius proximal to the sigmoid notch, ulnar tendinitis, which is the inflammation of the extensor or flexor tendons, chondral lesions caused by degradation of joint cartilage, and ulnar styloid impingement syndrome, which is the ulnar styloid process impacting upon the triquetral bone. TFCC is managed through rest, police, activity modifications, splinting, NSAIDs, possible steroid injections, strengthening, physical therapy, and possible surgeries. The athletic trainer will refer a patient with TFCC to a physician once diagnosed and will be immobilized with splinting or casting. TFCC can be avoided by reducing repetitive motions and activities, using correct biomechanics and correct equipment, strengthening, and possible occupational therapy. The Mulligan techniques used for TFCC is the dorsal sliding technique, the volar sliding technique, the ulnar sliding technique, and the radial sliding technique. The dorsal sliding technique is used to promote wrist flexion. The volar sliding technique is used to promote wrist extension. The ulnar sliding technique is used to promote radial deviation, and the radial sliding technique is used to promote ulnar deviation. My PCOT analysis is over a 70-year-old male who underwent TFCC tear surgery and used bracing afterwards, which increased his range of motion. This bracing was used for 12 weeks and showed major improvements.